see which window I'm sharing here. Okay. Okay, I just have a couple of cases this week, and this one is just, I thought, a really nice case. This is I believe a woman in her early 60s or late 60s who has this CTA. Let me show you this. And this was actually done as part of there was a PET CT that was done that I'll show you next, but it was done for, I believe, a mandibular cancer. And as you're going through, the findings are not really that dramatic, but you can see that there's some mild thickening of the circumferential thickening of the descending aorta. And I'm going to scroll up to the top of the case here. And you can see that the thickening goes all the way up to involve, really it's hard to perceive here along the arch vessels, but just some mild thickening of the aorta. Even the ascending aorta has some mild thickening. Going into the abdomen, you can see that circumferential kind of, just mild thickening. But the really dramatic thing here is, let me pull up made a movie of the PET scan, and let me pull this up here, fighting with the system. And see the PET up here, we can see that there's just dramatic circumferential FTG uptake of the entire aorta, extending all the way up to the arch vessels, to the subclavian arteries going down, extending all the way down. So, and it goes all the way down to the abdominal aorta there. So, this was thought to be possibly a giant cell arteritis, and the patient just had a temporal artery biopsy, and this is a giant cell arteritis, aortitis. So I just thought that was a dramatic, PET uptake here for something that on the CT is really not as dramatic.
What was the time interval between the CT and the PET?
Oh, just a few days. Yeah, because the CTA was actually done in response to this. And this was an incidental finding, as far as I can tell in the notes. This was done as a staging CT. So, PET CT. So, but yeah, thought that was dramatic. Okay. And here's another case. Let me show you. This was just a device that we hadn't seen before. Let me bring up the window here. Okay, and this is a patient who came in on presentation with this pseudoaneurysm of the ascending aorta anteriorly that was it's thought to be a mycotic pseudoaneurysm. Contrast getting into this saccular pseudoaneurysm here anteriorly, and you can see that there's a metastyle collection here, in the vicinity of the pseudoaneurysm. And the interesting thing is they put an endostent in the ascending aorta, and I don't have the particular study on which we had already put an endostent, but it was still leaking. And so here's an interesting procedure or device that, let me bring this up, that I was unaware of. You notice this, let me bring up, sorry, I'm fighting with my machine here. Wheel is spinning. Yeah, the wheel is spinning here. Let me see if it's having a little bit of malfunction.
I think we lost him.
Sounds like we lost him.
Brett, yeah, it's weird. Show him still connect. There, he's reconnecting.
See the angio now, and so one interesting thing about the angio is that you can see there are two endographs here. They're overlapping endostents here, and you can see that this is something I've never seen on. Art Stillman shared this with me. I've never seen on an angio before, where you can actually see the proximal. One cause for the endoleak that we had on after the endosome was placed is that there's incomplete apposition of this aspect of the proximal endostent to the aortic wall, and you can literally see that flapping right there. So very interesting. And you can see on the second set of images here that we have a deployment system down here for, and if this will start, there we go. You can still see the flapping there, but this is going to deploy an endo screw or an endo anchor through this big deployment device, and you can barely see the kind of the undeployed endo screw there, and now it's going to come out, and we're going to twist into from the endograft into the aortic wall here in a second. So you can see the device is going to deploy. I think it's in the next frame. Actually, let me skip forward. The endo screw is coming out, and it's actually literally going into the aortic wall, and it's anchoring this portion of the proximal stent to a portion of the aortic wall. And this is called the Helix Fx system, and it's apparently designed so that you can, this whole screw is designed so that it will penetrate the inner wall of the aorta, the intima and the media without fully, of course, perforating the adventitia and causing, you know, a leak at the site. So it's a endo anchor or endo screw, and it's designed to anchor this down to the wall so that you can decrease the endo leak. So you can see after that anchoring, there's no flapping anymore. So I'm not showing the follow-up angiogram. There you can see the endo screws, and normally a couple of these are apparently deployed where we just have someone who started to do this particular procedure. But you can see that now, after this deployment of 2 endo screws, you have much less movement of that, and it's opposed to the aortic wall there. So, and there are a couple of studies apparently on this technique, and have you all seen showing that it does help to decrease the incidence of endo leaks after deployment? So have you all seen these yet, these endo anchors?
Nope, not that I've.
Not yet.
But I think it's fascinating technique, and you know, this actually did dramatically decrease. I think we may still have a tiny leak on the follow-up, but it dramatically decreased the size, and actually they deployed 3 screws, it looks like here. So anyway, I just thought that was an interesting, very interesting technique, endo anchor. So anyway, those are my 2 cases this week.
All right, thank you, Brent. All right, who would like to show the next set of cases?
I can show 2 or 1 in particular.
All right.
So this one is interesting. I haven't noticed this before, and I want you to confirm the observation and see what you think. So let me bring up 2 images side by side, and one of these I'm going to make a MIP image just to try to bring out what I'm going to show you. So the history is that this person had a dissection some time back, and clearly they have put a tube graft in the ascending aorta, buttressed with felt pledgets, and this is the dissection involving the descending aorta going into the abdomen. And this is a follow-up exam. As best I can tell, it's just a follow-up exam to look at the aorta in general and the caliber, presumably, of the aorta and the lumens and so on. So let me show you my observation, which is really subtle, and then tell me if you're convinced. So here at this time, we do have some contrast opacified blood in the false lumen, but not too much compared to the true lumen. So let me scroll down here, because I think I'm seeing a number of places in which very small fenestrations are present between the true lumen and the false lumen, and they appear as little contrast collections and little jets. So let me scroll through there and show you what I'm looking at and see what you think. So they're small, so just bear with me. Okay, so the first one I thought I saw was right here. And you can see it right there. So let me just scroll back and forth just through there. So sometimes you can see that a little bit better when you're actually scrolling. So that's one location right there. And then as I went down, I thought I saw another one here. So again, to my eye, what I perceive is seemingly a little jet right there, right there, and there, and right there, as in there.
And Howard, that one in particular, you can see, let's see here if I can do this. You can actually see it going all the way through the false lumen.
It sort of goes like that.
Yeah, you can see that. You can see this little. You have it. You have the contrast just right that it's easy to see that little jet.
Yeah. And then I thought I may have seen a little harder, but I wondered about there, but maybe, no, there may be a little jet trying to get through. I'm not sure about, I don't know about this one right there. But, I get the idea that I'm seeing tiny, tiny fenestrations through which there's squirts of contrast or pacified blood popping into that false lumen. We often wonder where fenestrations are. I mean, lower down there's one here, which is pretty obvious down here. But I like to think that there may be tiny fenestrations. Oh, look at that. Isn't that interesting? I don't think I saw that one before.
One right there at the celiac or SMA, wherever you are. Yeah.
Yeah. Do you agree that they're probably tiny, multiple little fenestrations?
Absolutely.
Yes.
And
The more you see.
The surgeons will say, at least with IVUS, that they see a lot. And I think that sometimes explains why endovascular stents succeed in some cases for type B dissections and fail in other cases if there are a lot of fenestrations versus just one large proximal fenestration.
Yeah. Yeah.
Hey, Howard, do you think that some of those are where, the intercostals were and it caused a rent, where the intercostals were?
Brent, you mean like they're the source of where the little branch artery pseudoaneurysms would have originally been?
Yeah, and some, well, certainly not in all those cases, but in some of them, could some of them theoretically be due to that?
I don't know, because I think I don't know, because I think that's intercostal, isn't it, there?
Yeah, that one looks kind of like, yeah.
No, I don't know. I thought they were just tiny intermedial disruptions, fenestrations. I'm not sure.
It's interesting.
Well, in some cases, the intercostals come off here from the false lumen, right?
But they used.
Sorry, I think I heard maybe David making a comment.
No, that was actually Art Tillman. He was saying that that's where they originally were, opposed to the intima, so that when the intima is pulled away,
yeah,
well, could be there.
When it's pulled away, it's where the intercostals would come off. Yeah, I didn't think about that per se. I have to think about that. But I'm not sure I've noticed this before. We obtain thin cuts now, and I just happened to notice it in this patient, and haven't really thought about the implications of that, other than I'm sure this occurs a lot. We just don't see them, right? Okay. This is a nice type A aortic syndrome. So the resident, one of my residents that diagnosed this is sitting next to me. So this is a great radiograph with abnormal mediastinal contours. And yes, indeed, this is the involved portion of aorta. So this is kind of an interesting looking and large type A dissection. So we have intermedial flap in that location, and there's quite a large communication, of course, here between true lumen and there. So that's pretty large. What's interesting is several things. One, there's quite a lot of opacity here inferiorly. So this is atrial appendage that appears a little compressed and displaced by something. So the non-contrast containing something down here near towards the aortic root and then the non-coronary sinus. And then let me just go to the axials here. Actually, I want to show you the non-enhanced. When I looked at this, I couldn't really perceive any hyper-attenuating clot in relation to the aorta. If it's there, it's got to be really subtle. But if I had looked at this, I would not clearly have perceived hyper-attenuating clot anywhere in particular. There is some pericardial fluid there that you see there. And then going again now to the contrast sequence of the same exam, you get a feel for where the contrast is and where there is some pathology without contrast, like down here. So I thought that's really interesting configuration. Here's the op report. So interestingly, he had pericardial fluid, and I'm not sure what prompted the surgeon to make that comment, but that's interesting. A profound Dresless-like inflammatory response within the pericardium. Obvious large ascending aorta aneurysm with a large intramural hematoma. The intermedial flap beginning at the sinotubular junction. Large intramural hematoma extending proximally down the aortic root, especially in the non-coronary sinus, which I presume is this portion down here in particular. Any thoughts about that case other than there seems to be a good anatomic correlation between what we see and the op report in general?
Howard, doesn't it look like there's some thickening there if you come up along the aortic root, along the right lateral aspect, and you know, like in that area.
Are you looking?
Kind of, oh, to the right. Yeah. The right lateral aspect, it looks kind of thick and, you know, like it's a IMH that's complicated by dissection, maybe.
Yeah, I think the wall, there's pathology in the wall there, I think. And then there's contiguous pericardium here. And maybe more pathology in the wall coming down here, I presume? Well.
Yeah.
Because interestingly, there's a large intramural hematoma in the aortic root, especially in the non-coronary sinus. This is the op report. And I presume it's this down here. That's described as that.
Yeah.
Right down there. So it's kind of an interesting way how this dissected and where it bulges and where the false lumen is so abnormal. And then that pericardial fluid or reaction, which interestingly the surgeon described that way. So this was repaired, but I thought there was some interesting anatomy in this patient and some interesting, somewhat variant findings in otherwise straightforward aortic dissection, I think. Any other comments from anyone else about the anatomy or any other weird findings? Okay, Jeff, those are my two cases.
Thank you, Howard. Okay, David or Travis?
I have a couple.
All righty.
So can people see a röntgenogram?
Yep.
Okay, this person has all of these tiny little, very bright dots throughout the lungs that were interpreted as, on one exam, as artifacts, and on another as aspirated barium. These were there on a radiograph at a few months different time point, so they're not transient sorts of things. This was a patient with sickle cell anemia, and he came to our emergency room with obvious drug-seeking behavior, and this man actually travels around the country going from ER to ER asking for intravenous Demerol. And so this is actually metallic mercury here from mercury injection. He had, somebody had for him installed a PIC for him. So for his venous access, he said it was installed by a hematologist in Tennessee, but there was no documentation that was the case. So this man likes to inject metallic mercury, probably from thermometers. And I'd shown a case like this a year ago, a different person. And this was not tumbled to by the radiologist who interpreted this or the other exam. We don't have a CT scan to go along with this. We only have 2 chest radiographs, and they both show this these fine metallic particles in the same distribution. So people can get high from injecting the metallic mercury. Probably when it hits the lungs, it releases some cytokines, and they get a kind of rush. I don't know whether you guys have seen this at your institutions. I did show a case a year ago. So heavy metals, dude, heavy.
David, can you show the lateral? Is there any accumulation in the right ventricle?
Well, you have this anterior stuff here. Let's see if that corresponds. So I'm looking at, I'll just window this down here.
Because I think I had one case from St. Louis when I was a resident that I think I managed to find last time when you showed the other one.
Yeah.
But yeah, I still have never seen, yeah. It looks like it's kind of preferentially layering there.
I think that's a very good point. And then I don't know how this stuff got down here. It looks as if it's actually in kidney, don't you think? How would this stuff get through? Yeah. That would be strange. Maybe he's shunting. Maybe he has some, maybe it's shunted across the PFO or something like that. Maybe there's acute hypertension.
I guess it could, yeah.
Okay, he's probably got in his brain too, but he doesn't use his brain that much. Okay, so I wanted to show you this person with this, I think, sort of distinctive pattern of lung fibrosis here. This is a woman, I think, at this point in her 30s, and she's been sick since her early 20s, and she got a biopsy back 10 years ago. And let me show you her CT scan first and see if you can predict what the biopsy showed. So this is her kind of lacy pattern of lung fibrosis against a background of emphysema. So upper lung predominant, not peripheral, but sort of lacy looking, peripheral sparing, a little bit of peripheral sparing lung fibrosis here, combined with emphysema. So here's their biopsy site up here in the right upper lung. So what do we think, guys? This was Langerhans cell histiocytosis. So her CT scans and chest imaging that we don't have available from 10 years before at the time of the biopsy and diagnosis had shown nodules and cysts in the upper lungs and also some emphysema. She was a very heavy smoker. Well, she was a heavy smoker, a pack per day. She started young, but given the young age at which the diagnosis was made, even though it was confined to the lung, there wasn't any evidence by imaging of Langerhans cell histiocytosis elsewhere in the body. It's possible that this is really a sort of a Huntschuler-Christian non-smoking related Langerhans cell histiocytosis. So that young age is suggestive to me that that's a possibility, but in a cigarette smoker, it's probably variable how much cigarette smoking is required to do this. She's also used marijuana and amphetamines and alcohol, so it's quite a cocktail. So this pattern of fibrosis, I think, is pretty distinctive for a burned out LCH, and this was stable on CT scans a year apart, again, 10 years after diagnosis. So the other interesting thing happened with her is that she was given chemotherapy for her Langerhans cell. So she really got quite a cocktail, including vinblastine and vincristine. So she eventually developed a secondary complication of that chemotherapy, which was myelodysplasia and a refractory anemia. And she was treated with transplant. Then 28 days after her bone marrow transplant, she had a cerebral hemorrhage and she died. So this gave way to a secondary MDS-RAEB, and with consequences of death after transplantation. So I think the other thing that helps tie this pattern of fibrosis to Langerhans cell is the accompanying emphysema, reflecting her cigarette smoking.
Yeah.
Okay.
And David
Very interesting.
illustrates another, I think we've talked about before, is the relative preservation of the vasculature, which when it's pure emphysema, you tend to get these little spidery vessels, but these are pretty decent, healthy looking pulmonary arteries and veins. And hers,
Okay.
and hers isn't as cystic as some of the really burned out ones are, the really advanced ones that are end staged. That we sometimes see come for transplant billed as emphysema, but it's really mostly Langerhans. I mean, there's emphysema in there, but I found that that's one in any advanced cystic lung disease. I found that the preservation of the pulmonary vasculature is very helpful. You see that in lamb too.
Okay. So you think that most of these holes are probably cysts rather than emphysematous spaces?
Yes.
Okay. I think she's got bubbly lesions.
Septal emphysema. I mean, there's definitely both, but when I see a patient with hyperinflated lungs with lots of holes in them, but really relatively intact vessels, I favor it being cystic disease primarily.
Okay. Good point.
Yeah, interesting.
And let me show you a third case here of a diaphragm fluoro that I was asked to do. So this person has very low lung volume and has elevation of both heavy diaphragms. And on lateral view, you can see, and unfortunately lateral scout is all I have, that the heavy diaphragms are both elevated, but there's this pretty steep descent posteriorly, which implies the possibility that this is really large eventration rather than paralysis, because the heavy diaphragm in paralysis tends to maintain a high but shallow arc that goes all the way posteriorly. And this one dives back here. So this could be large eventrations. But then when we look at the cross sections, we see that both of the crura here fairly thin, not atrophied completely, and there's still a little bit of Crus muscle here, but pretty thin. You know, so you kind of wonder, is this really a paralysis with a funny shape to it? So we did fluoroscopy on him, and I want to emphasize the helpfulness of lateral fluoroscopy. So this is frontal fluoroscopy, and you can see that there is some motion of the dome of the heavy diaphragms here as the person takes in a deep breath. And then this guy got the idea that he had to take a super deep breath, and he started really exercising his chest wall. You can see us throwing his neck back and stuff like that. He thought he was helping by really exaggerating. It's really hard, you know, to get somebody to just breathe quietly or take a deep breath when you instruct them to do that. When the conscious mind interferes with breathing, it causes all sorts of confusion for people, and people will do funny things like snort, or they will, you know, you ask them to take a breath in or sniff, and then like that. So it's really hard when you confuse them with their conscious mind. But even on the frontal view here, I want you to look at the lung vessels in the base back here behind the dome, and you'll see that the motion of those posterior vessels, the most propelled by the posterior diaphragm, is a lot more vigorous than what we're seeing with the dome of the diaphragm. And this is characteristic of eventration, that there's a little motion of the dome, but there's a lot of motion posteriorly. So you get a hint of that here on this frontal fluoro, but it's harder to see than it is on the lateral. So here's the lateral fluoro, and let me show you what this looks like here as the person breathes. You can see that there's relatively little motion anteriorly here, but there's a ton of motion posteriorly when the person takes a deep breath. See how vigorous it is posteriorly? So, and you can see that the same thing is happening on both heavy diaphragms. So the lateral fluoro is really very, very helpful in showing you that there is still very good orthograde motion here of the diaphragm, and this therefore cannot be paralysis. But so this anterior elevation here, despite its size, is just eventration. It's very large eventration, and despite the thinning, the sort of thinness of both crura, this is not paralysis. So lateral fluoro is very helpful here in distinguishing these large eventrations from paralysis. Okay.
All right.
So those are my teaching cases. Thank you.
Thanks, Dave. All righty.
Great, thank you.
Alice, would you like to go?
Sure.
And then do a lateral.
Okay, really quickly, we will revisit this. This is the case I have from St. Louis of mercury injection. And yeah, it's the same tiny little punctate metallic fragments and then the stuff that likes to accumulate in the right-sided heart chambers. So I think that's a useful clue in these cases, since it makes sense it has to get to the lungs via the right ventricle. And so I have no idea how long that stuff actually stays there like that, but it's very similar to your case, David.
Yeah, that's a great example. Thanks for pointing out that RV thing.
Yeah, that's what I remember from this case. So, all right, let's go with this one first. This is from yesterday, and this is if Art and Brent are still on there, and everybody will appreciate this. So we've got a couple of different abnormalities here. The left SVC and the big superior intercostal vein are the least interesting things about this. And this guy originally underwent a CT for I think it was to evaluate for thoracic aortic aneurysm because of his question, some sort of tortuosity on a radiograph. And this is a total incidentaloma in this case, but you see there's this weird thing in the RV outflow tract. And it turns out to be an enormous sinus of Valsalva aneurysm arising from the right coronary cusp. And, you know, I haven't had a chance to look at the echo report yet because I just was shown this case yesterday, and this is a VA patient. But it's amazing that it's you know, prolapsing into the RV outflow tract here. This is all the sinus of Valsalva aneurysm. And his right ventricle does look a little, you know, it's definitely looks a little dilated and maybe a little hypertrophied here. So I wouldn't be surprised if he has some degree of outflow tract obstruction from this. And it hasn't ruptured at this point. This is actually a follow-up exam. But this is by far the largest sinus of Valsalva aneurysm I've ever seen. And the one thing that's kind of curious too, if anybody has any comments, is the fact that while it is from the sinus, it is more, you know, the inferior portion of the sinus of Valsalva below where the right coronary artery comes off. So I don't know if anybody has any comments on this, but this is, of course, the right coronary sinus is the most common for a sinus of Valsalva aneurysm. And if this guy were to rupture, it would undoubtedly rupture into his RV and just present with high output cardiac failure. So he might actually, you know, might be able to survive a rupture of this thing. But I think now they've discovered it, they're going to go fix it.
Hey, Travis.
Yeah.
That's amazing. Do you think, what is that thickening there anteriorly? Is that some thrombus, or is that?
I think so. Yeah, and that was actually when the that one dissection, you know, when you guys were talking about the dissection earlier, I was thinking about this too. There's accumulation of stuff in here. I don't know. I don't know if it's just that it's being indented by the RV wall. I think you're probably right. I bet there is some thrombus in it.
And why
slow flow.
Do they have an independent reason for the RV thickening, the wall thickening, or is there already?
No, that's why I wonder if it's related. He doesn't have any underlying lung disease or any explanation for why he'd have pulmonary hypertension. I bet it's outflow tract obstruction from this. But I haven't had a chance to look at his echo yet because this was a VA patient. But yeah, I mean, this thing is enormous, and you can see how much of his RV outflow tract it's involving.
You have this entire room enthralled right now. So
good. All right.
So, Jeff, are we going to make the Caney conference point that?
Oh, the multiple abnormalities.
Yeah. So this is a sinus of Valsalva aneurysm that is causing a left SVC, right, Jeff? Right.
All right. Well, this case, everybody back in the reading room in Atlanta is going to remember that this is strikingly similar to a case we had probably 2013. The only difference is the age of this patient. Now, this is an 11-year-old girl, and can't see her sternal wires on here. I don't have the radiograph, but she underwent a VSD repair some time ago, and my understanding is she was adopted. They don't really have great records of what happened, but she was persistently hypoxemic and actually has been cyanotic. And so the question was, does she have Eisenmenger physiology and pulmonary arterial hypertension from the shunt that was corrected, or does she have a shunt? You know, or did they fix the VSD, or is there something else going on? And I'm going to show you the just timing bolus here, because we fortuitously injected in a location where we will see that the first place that gets contrast is here in the left atrium. And then we see the left atrium, the aorta gets contrast, still nothing here, and then eventually we'll go and we'll see the blood recirculates and we have contrast in the SVC. Now, I've shown a case almost identical to this in a woman who was in her, I don't know, 40s or 50s, who had had an ASD repair, a secundum ASD at that time, and didn't get any better in terms of her symptoms. And it was the exact same explanation. So here, when we actually look at the study and we see this arterial phase, we see it's because, as you might have guessed, she has bilateral superior vena cava, and her left SVC drains directly into the roof of her left atrium. And so we fortuitously injected through her left upper extremity. There's maybe a tiny little, I wouldn't call this a brachiocephalic vein, but some sort of little vein that connects. But this is, if we had injected through the right, we would not have seen this dramatic timing of the contrast. So this was an unrecognized, undiagnosed right to left shunt that was associated with, here's her VSD repair. And so the technologists, of course, noticed that something was wrong and they did a delayed. And now we can see on the delay that we have filling of both of her superior vena cavae. So this is at least the second case now I've seen of this being associated with other congenital heart disease, where it was undiagnosed and patients underwent repair of other abnormalities without having this noticed. And so, of course, she doesn't really have much of a coronary sinus or any real coronary sinus here, maybe a tiny little bit just draining the veins, which is really interesting too, because you can have left SVCs that communicate with the left atrium via unroofed coronary sinuses, but this is just more going straight into the roof of the left atrium and into her, and not into a coronary sinus. So I thought this was a fascinating case, and the fact that I've seen another one identical to this. So just remember, when you see a left SVC, always look and make sure it's draining into the coronary sinus as it should.
So Travis,
yeah.
there's something called the Raghib syndrome or complex.
Right.
Combination of left superior vena cava draining into the left atrium, ASD though, and absent coronary sinus. That's that syndrome. This one is a variation on it.
This is probably a variation on the Raghib syndrome then, yeah. So, yeah, but it's
does she
similar.
have what's that little calcium there? Does she have an ASD?
No, I bet this is, I don't know if this was probably related to her surgery when they went in and repaired the VSD. I bet they did an atriotomy at that time. I don't know. The other thing is that she does have this weird little thing right here, and I can't tell, there's a little bit of motion. I can't tell if this is a little accessory left atrial appendage or if this is actually communicating. I think it probably is communicating. So she might have a tiny ASD, I don't know. But she hadn't had an echo recently, or she had a transthoracic echo, but not a TEE, because they obviously didn't see this on the transthoracic echo and suspected that she had pulmonary hypertension, which her pulmonary arteries are mild, but obviously we have a better explanation for why she has a frank right to left shunt. And then I want to show this one. This is, and then I'm going to show a companion case. This is one that came to us from the outside. And I pulled up one of Jeff's old cases because the only reason I was suspecting this was because of a case we had and discussion we've had in the past. But this came billed from an outside hospital as a thymolipoma. And I will admit, I still have seen exactly 0 thymolipomas in my career, including on this conference. And I know Melissa Rosado de Christensen was part of some big pathologic study in the 90s where they reviewed 30 or 35, but I still do question the existence. So this was sent to our tumor board and sent to the surgeon as a thymolipoma. So he went in, unfortunately we didn't get to review this ahead of time, but went in to take this out and of course discovered that that's not what it was, and this is insinuating and infiltrating everywhere. Ended up where he avulsed the origin of the subclavian artery, had to call the vascular surgeon in to repair things. This had been just incidentally discovered, by the way, but of course, if anybody wants to take a guess on what they think this is, and I'll show Jeff's case that was exactly like this.
Is it a liposarc?
Yeah, this is a low-grade liposarc. And the question afterwards was, well, how do you know that based on these imaging? Because when I saw this, I was like, I think this is a liposarc. Because there isn't really a lot of fat, or there isn't a lot of soft tissue in it, but it is infiltrating. It involves multiple compartments. And that was the reason I guessed that. Here's the one that Jeff showed a few years ago, which has even less, less soft tissue component to it, but almost identical though, in the sense that it's involving the anterior, a little bit of the middle mediastinum, and just kind of insinuating along everything else. So the challenge is still out there for somebody to show me a path-proven thymolipoma. And I don't know, I looked through Jeff and Howard's databases, and I still don't see one on there either. So has anybody actually seen one?
I don't think so.
Because I think we had this discussion probably prompted by this case in the past, Jeff, if you remember.
Yeah, I mean, the thymolipomas are described as these huge, they just kind of flop over things. They don't really insinuate themselves anywhere.
Yeah.
But, yeah, I agree. I wonder if it's just a big mediastinal lipoma with some residual thymus hanging around.
Yeah, but yeah, as David said, mine was a liposarc just like this was. And I think that other than the fact that I haven't seen a thymolipoma before, and that mine was involving multiple compartments like this was the reason that I would guess that.
I have two possibilities I'll look up. So I may have two cases.
Okay.
I'll show them next time.
Jeff, do you mind if I show this arch really quick, or do you?
Go ahead.
Okay. So I sent this out to some of you, and this was one from last week, and this is the weirdest arch I've ever seen, admittedly. Now, this is a patient with a TET repair, and this is just to assess their, kind of an anatomy checkup before they do a pulmonary artery or pulmonary valve replacement. But they have a right arch. There's no arguing that. And when you follow the branches, if we start in the ascending aorta, you see the first branch they have is this tiny little thing right here. And it goes up and it goes around the thyroid. And then it looks like it goes right next to the left internal jugular vein and probably in the left carotid sheath, like the carotid artery would do, except it's a really diminutive vessel. And that's vessel number one. Vessel number two is this right-sided vessel that looks like a right common carotid artery, certainly larger than that other wimpy little thing here. And then you keep coming up and you see that there's a retroesophageal aberrant vessel, which is kind of peculiar because it branches right here. It actually branches again. I thought at first this might be the vertebral artery, but then you follow it up and you realize the vertebral artery is actually this branch right here, which comes off the left subclavian, which is this other branch. And unfortunately, we don't go up any higher than right here. But I suspect that this is probably separate origins of the left external and internal carotid arteries. And I've shown a case before of a cervical arch where there were separate origins, not like this, where one was retroesophageal and the other one was not. And then, of course, the right subclavian artery comes off here in the right vert. So I don't know if this is high enough to be a cervical arch. It does go pretty high. I think Jeff and David both weighed in and thought it probably wasn't. I mean, regardless, this is a totally weird arch that I've never seen before. I did make some 3Ds. I mean, there's a lot of separation between the pulmonary artery and the peak of this arch, if that makes any difference. But I'm just curious if anybody else wants to weigh in and say and add anything.
Right arches are often higher than left arches. So to me, this is in the range of what a regular old right arch does, which is go up somewhat higher than a left, but not all the way into the neck. Can you show that the Ton case by any chance that he sent a couple months ago?
Yeah, let me actually, that reminds me, I was going to show that. Let me pull that up right now. Let me see, it must be, I don't want to reveal the names because I do have a couple of, I think that I haven't anonymized here. Here's Ton's case. Yeah, and then this thing right here. And this, thanks, yeah, David, you were the one that pointed this out, but here's this patient's arch. And I agree, without a doubt, yeah, this trumps mine in terms of how high up it goes. So certainly they're different. But in this case too, David, I noticed that if you look on the neck, you see that there are separate origins of the right carotid, internal and external right here, as you typically see with a cervical arch. But this one was even more interesting because I don't know if it's a double arch with an atretic segment based on where the left carotid is and the fact that it's a right or left-sided descending aorta. But yeah, this one I agree is certainly is going to be a cervical arch,
Mhm.
but also a weird variant. So
going back to the point that I was trying to make before about a right arch being higher than a left, when you have double aortic arch, the right arch is always higher than the left. So it's part of, I think, being a right aortic arch is wanting to be higher than a left arch would be.
yeah, it's almost always higher and usually larger too when you have a double aortic arch. That's a good point. So yeah, mine probably isn't a cervical arch, but it certainly is a weird variant.
Yes.
So
Yes, yeah.
all right,
Excellent.
cool. Well, I will stop there and let Jeff show whatever he has.
Well, I'm going to continue along this theme here of aortas. So let me show, I've got two cases here. I'm going to start with one of them. Let me load it up. So these are two young adolescents who both have bicuspid aortic valves. And I'm not going to show the whole MR. I'm just going to show the 4D flow because it shows two different patterns of flow. So this is the first patient. You guys should see, this is the 4D flow. And you can watch. So we see during systole here, we see this jet coming out. And you'll notice there's sort of red flow along the more lateral wall of the aorta. And there's a little bit of a sort of an eddy current going on here. Now I'm going to show the other patient. Contrast. Let's see if we can get back here. Let's see. You guys should see this one. Now you'll notice this current is more laminar. So interestingly, I was talking to one of my colleagues about this, and the importance of this has to do with the stress on the. So in this patient here, so this is the one where we see the, I've got them mixed up here. Let's see which one we got going here. Yeah, this one we see more laminar type flow. So apparently it has a different impact on the aortic wall stresses, and you get more dilation when you have that off-center flow jet. So the first patient I showed, which I can bring back up, there's more likely to be dilation of the ascending aorta because of the stress on the wall, whereas when you have laminar flow, the pressure, the forces are more evenly distributed, and so the aorta is able to cope with this. So this is one way to sort of decide how closely you're going to watch someone's, how the timing of surveillance for aortic dilation, as well as echo looking at the valve. But this is kind of neat using it, which is becoming more and more commonly used. You can also look at distensibility of aorta, pulmonary arteries, and things like that. But I'll send the whole case along if you want to go through the other sequences as well. Okay.
So this has to do with bicuspid aortic valve, and depending on which commissures are fused, the direction of the jet is different. And in one case, I forget, right-left fusion, it'll impact the lateral wall, and that'll dilate in a certain way. And if you have